This is the time to start the program for the Dominican Medical Association. And I would say that the Dominican Medical Association is going to start presenting the 12th Medical Symposium. The reason is that we've been waiting for that because remember, 2003, we had JNC7 and the classification of hypertension, and we've been guided by JNC7 for the last 10, 11 years. And
Okay, let's go through then the JNC approach to a patient walking into your office. An adult aged greater than 18 years old with hypertension by a usual criteria that you would use walks into your office, and what do? Well, the first thing is you confirm it. The second, once confirmed, you initiate lifestyle therapy and you continue lifestyle changes throughout. So you would recommend the individual to not add salt, but more importantly, to become aware of all the salt that's added to everything we eat today and reduce the salt intake. They didn't give a guideline, by the way, of how many milligrams of sodium a day or sodium chloride. They talk about exercise, they talk about smoking and so forth, but lifestyle goals. And the person comes back and is doing all right. But if you discover in the lab test that you do that the individual has diabetes or chronic kidney disease, you then start a different approach. That's shown on the right side of the slide. So diabetes or CKD present leads you to start to set a blood pressure goal of 140/90, and similarly, all ages CKD present with or without diabetes, 140/90. So in a sense, your initial blood tests, your initial, if you will, risk stratification will guide you where to go. But what if they are free of diabetes and CKD? Well, if they are if they're below 60, you hope to keep them below 140/90, but you don't necessarily have to start drug therapy if they are 135 or 85. If they're greater than 60, it's even higher, 150/90. So the age over 60 gets you 10 more points, if you will, assuming no other complications. And now we go down a little further. If they are African American, you start a thiazide-type diuretic or calcium channel blocker alone or in combination if they are having a blood pressure that exceeds one of these age-related bases. If they're not African American, you can still use a thiazide or an ACE or an ARB or calcium channel blocker alone or in combination. And then you bring the individual back for further assessment on a monthly basis, and you add additional drugs, maximizing the first medication to the level shown in the previous slide, then adding a second if you haven't already done so before reaching the maximal dose, or starting with 2 medication classes separately or as a fixed dose combination. There are multiple approaches that can be taken. The goal is to simplify the approach for these individuals. Now, what else do? You reinforce medication and lifestyle adherence. If they're at their goal blood pressure, you're happy. You keep reinforcing lifestyle adherence. And after 3 chances, if they're still not at goal, you try to send them to somebody else to add other agents and to consider a tighter management of their blood pressure. So, thank you very much for your attention. Oh, sorry.
Thank you. And our next topic deals with something that a lot of us are still confused. It's a concept of what is a medical home? What is the purpose of the medical home?
Muchas gracias. Thank you very much for inviting me. It's a pleasure to be here. Let me ask, how many of you practice in Washington Heights, Inwood, or the Bronx, or West Harlem? Okay, so it's a good number of you. And how many of you have electronic medical records in your offices? And are there some of you here who have converted into patient-centered medical homes? Some. Okay. All right. Well, today's talk is going to touch on all those three issues, and I think, as Dr. Moran pointed out, there's going to be increasing relevancy of these topics. The first is population health. And I'm going to be addressing what New York Presbyterian Hospital has been doing in Washington Heights Inwood. Right now, we have health reform. We read about health reform, federal health reform, Obamacare, about its impact on insurance, its impact on practices. But there is a tremendous effort going on in the state with health reform that's going to impact each and every one of us in this room, and I'll say a little bit about that. The patient-centered medical home is the basis, the core of what the health reform is going to bring you towards. Basically, what is called value-based purchasing, basically where the insurers and the hospital and the government insurances are going to look for how you get the quality for the patient while reducing the cost. Not just the old fee-for-service where we think that something is good for the patient, we just do it and do more and repeat the test and get 3 times. This is something that's going to be changing quite dramatically. So I'm going to talk about transforming care, giving you sort of a background on what has been happening in Washington Heights Inwood. And the first item in that is going to be how do we address the needs in the community. Again, value-based purchasing has a real emphasis on what the needs are for the community. Secondly, how do we build a patient-centered medical home? Then I'm going to give you some outcomes that we've had after 3 years of practicing population health with medical homes in this neighborhood. Outcomes which are different from the JAMA article and which are right now are under review for publication in Health Affairs. Thank you very much, everybody.
So for those who doesn't know me, I'm Dr. Miguel Hernandez, psychiatrist. I'm the co-chairman of the DMA. I want to say thank you again on behalf of the DMA, Mili and Ofieri. Thank you, Dr. Lantigua, for helping the DMA in putting together this CME program for the last 5 years. Thank you. To be talking about this important topic. In primary care setting, we miss a lot child abuse. Even psychiatrists, we miss child abuse. So without further ado, let's welcome our next speaker, Dr. Tricia Gibbs.
Thank you very much for the introduction. Okay. Hola, buenos dias. It's really a pleasure for me to stand with you all and also to be back at Columbia, where I went to medical school and residencies, and I worked in Cosmo when I was a medical student, so I had lots of great training here. My private practice has only been open for the last 3 years, just to correct that, but in any case, I'm going to be talking with you about child abuse in primary care. So I'm a child and adolescent psychiatrist, and I'll be referring to most of my experience at in Bellevue Hospital and NYU Child Study Center in terms of my experiences with patients. And I'm attending in the child psychiatry emergency room. So I have no disclosures to report. I actually didn't put the slide in, but I'll say I have no disclosures to report. And I wanted to ask how many clinicians here work with children? Okay. And how many of you work with parents of children? Okay. April happens to be Child Abuse Prevention Month. So this talk is very timely. And during this talk, hoping that you will leave with the ability to describe the 4 known forms of child abuse, their prevalence, and the common presentations to the primary care physician. Also to describe the primary care clinician's role and responsibility as a mandated reporter, and also explain barriers to physician reporting. Thank you very much.
Of transplant physicians in 1986. He received the Senior Attending Teacher Award from NYPH Hospital at Columbia University in 2009, and he was the American Liver Foundation New York Charter Physician of the Year in 2010. It's an honor for me and to all of us to have Dr. Brown here today. Dr. Brown?
So right now we have interferon-free therapy that's approved for genotype 2 and 3, and short course interferon, 12 weeks, for genotype 1. And this is the studies that led to approval. This is sofosbuvir, called Sovaldi. Everyone's seen it in the newspaper, usually related to the cost and how much money Gilead is making on this drug. I guess it's good if you're Gilead. I'm not a stockholder. I haven't made a dime off of it. So it was treated 12 weeks, every genotype besides 2 and 3, 1, 4, 5, and 6, for 12 weeks of therapy, and then the therapy was stopped. And you can see, here are the cure rates. It's 90-ish%. The only people who didn't do great were the patients with cirrhosis who were genotype 1, where it was still 80%. So you can see whether you were African American or Caucasian, had high viral load or low viral load, had the IL-28B/CC, the favorable type, then you were 98% basically assured. If you were not, so you could see across the groups 90+%, a new bar with only 12 weeks of interferon, where before they were taking 48 for 40%. And there was no resistance to this drug. Everyone who relapsed, the 10%, but they relapsed with wild-type virus, and 98% of patients could complete the 12-week course. Because they weren't taking 48 weeks of interferon, 1, they had fewer side effects, and 2, when they had those side effects, knowing that the end of the road was at week 12, almost everybody completed, even those with cirrhosis. Cimeprevir was also approved. It's a protease inhibitor, like telaprevir and boceprevir, but with fewer side effects. The problem is it's used for 24 weeks. And the response rates are not that high. So most people have said, well, why would I treat someone with 24 weeks of pegylated-interferon, ribavirin, and cimeprevir for an 80% response rate when I can treat with 12 weeks for 90%? And the answer is, there is no reason. We don't do this. But I'm showing this for a reason, and that'll become apparent in a moment. They do have resistance, because all protease inhibitors have resistance, and those 20%, most of them do develop resistance. But this was much better tolerated than telaprevir and boceprevir. There was no serious rash. There was no incremental anemia. So 98% of patients actually completed 24 weeks with this regimen, as opposed to only about 80% of patients completing 24 weeks with telaprevir. And this is the reason why cimeprevir is important. A phase 2 study combined the protease inhibitor semaprevir with the nucleotide sofosbuvir with and without ribavirin for 12 or 24 weeks, both in cirrhotics and non-cirrhotics. This study was called the Cosmos study. This did not get approved because the number of patients was too small to establish safety of a previously unapproved regimen. But you can see that the response rates are quite considerable. Remember, we had 90% with interferon. Now you can see 12 weeks with no interferon and no ribavirin is offering over a 90% cure rate for genotype 1, even in those patients who have cirrhosis. Even in those patients who have cirrhosis who failed prior interferon and ribavirin. Now, these are very small numbers of patients. This is not an FDA-approved regimen. But Sovaldi or sofosbuvir is approved. Semaprevir or Alisio is approved. This is the first prescribable interferon-free therapy for genotype 1. And there are a lot of patients in the community who are taking this. And so far, there has been no post-marketing safety signal, but it isn't going to be studied because drug companies can't cooperate anymore.
The following speaker has a lot of publication. We can be here the whole day. He's an expert in addiction and in psychiatry. He's a double certified in general psychiatry and addiction psychiatry. He's the training director at Harlem Hospital. And he has other academic training, like he graduated in the University of London in biology and chemistry with honors. He has a master in public health in this university, and we can continue on and on. So without further ado, I want you to give an applause, and let's welcome Dr. Evarito Accarelli. He's going to be talking about opioid dependence treatment.
And how did we solve that problem? Let me see, any ideas? All right, the medication was given PO and it's supposed to be given sublingual. We know the conversion. We know that when you give it by mouth, it is 1/5 as effective as when you give it sublingually. So I just made that about a quarter. I said, did he get 8 milligrams? He said, yes. I said, okay, so that's about 2 milligrams really. So give him another 6 milligrams sublingual. And that's the way we solved it. Nobody needed to get in trouble. Nobody needed to be written up. And people became more familiar with Suboxone, and we had more discussions. Some of the resistance that we felt with Suboxone introduction was from counselors in the methadone program, from nurses, from our own physicians. And the reason you have all this resistance, the counselors came to me and said, look, I thought you were one of us. You want us to lose our jobs? With this Suboxone, we'll have no jobs. You see, the nurses came, and what did they say? You want to create extra work for us. So you have to sit down and talk to people and let them understand what is going on. And then with our physicians, many of them, even those who were licensed to prescribe Suboxone, say, I don't know what the heck and how to do it. You know, I'm just very worried about what could happen. And this is normal because when medications are under the eye of the DEA, nobody wants to get into trouble. Okay, so what I've talked about here is the definition, the prevalence, the signs and symptoms, and then the medications. And I've talked mainly about those that act on the opioid receptors, the agonist, the antagonist, and the partial agonist. Now I'm going to tell you about those that have nothing to do with the opioid receptor. And the reason we say that is that, you know, those are much, much safer. And number one in that is clonidine. Clonidine, actually, most people do not realize, was never FDA approved. It's a waste of time to get it FDA approved. And why is that? Side effect, possibly. It was working very well in the general population. Everybody knew it worked. For you to apply to FDA costs you about $1 million, just the application, not to talk about the processes. So it was working. Most physicians knew it was working. It just became generally used, and never was it actually submitted to the FDA as a drug for heroin detox. But it also has an interesting history. because the two people that discovered clonidine, one of them was a resident, the other one was an attending, and to this day, they do not speak to each other. Yes, gold and potash. Why is that? Well, I'll tell you why. So, the attending claimed that it was his idea, and the resident claimed that it was his idea. And nobody will give up on whose idea it was originally. So each one accused the other of stealing his ideas. And I was baffled when I found out this. I was a fellow at the time, and I said to myself, I said, look, I was speaking to our chair. I said, why is it that people fight like this over these kind of things? Why don't you just say, well, it was his idea. That's it. Let's forget it. I'll do some other thing. And he said to me, he said, listen, Evaristo, in our lifetime, bright ideas are very rare. They may come at the beginning of your life. They may come towards the end. They may come in the middle. But one thing is, you may never get another idea like that throughout your lifetime. And so people want to hang on to something that is very significant, and they want to be known as a person who discovered that. Because you may never have any great idea for the rest of your life. So, thank you.
Jason Gottlieb is the other expert that's going to help us. That's the second half of the tag team who's going to help us understand this. Jason Gottlieb is the Director of Revenue Cycle Academy for New York Presbyterian Hospital. In this role, he's tasked with improving revenue cycle and employee performance across several departments, including patient access, health information management, and patient financial services. He also contributes to compliance-related initiatives, most notably leading the organization's effort to ensure readiness for ICD-10. Please, would you help me to welcome Dr. Kaplan, Mr. Jason Gottlieb. Please give us a hand to see how we could understand a little, as much as we can, about this coding. Are we subcoding, undercoding, overcoding?
We'll try to help.
Thank you.
That being said, I'm not exactly sure. This was the first slide I expected to be presenting to you when we put this presentation together about 3 or 4 weeks ago for the symposium. But then again, this is not the first time that ICD-10 has actually been delayed. The proposal to implement ICD-10 was first surfaced in 2008 by the Department of Health and Human Services. They proposed an implementation date of October 1st, 2011. That was 4 years ago. That rule in 2008 was changed to October 1st, 2013 by the 2009 final rule. In April of 2012, the date was changed to October 1st, 2014, and then obviously here on April 1st, the most recent delay with the legislation now known affectionately as H.R. 4302. H.R. 4302 actually has nothing to do with ICD-10. It was drafted to install the 17th consecutive temporary fix to the sustainable growth rate formula for physician payments. ICD-10 was a casualty of war in this never-ending yet impressive demonstration of political indecisiveness. Okay? And in fact, the AMA, the American Medical Association, who's a vigorous opponent of ICD-10 at all, at any date, was really not the source of ICD-10's inclusion in this latest legislation. In fact, the AMA has been aggressively advocating for a permanent solution to the sustainable growth rate formula. And as the AMA president stated, we want to kill ICD-10, not delay it. And as the legislation is currently written, there is no implementation date. And of greatest concern at the moment is probably this, what I would call sonic silence from the Department of Health and Human Services and the Center for Medicare and Medicaid Services. They've said nothing. We've heard nothing. Okay. The turnover at the leadership level is not helping that situation at all. And it's left the entire healthcare industry somewhat perplexed as to what to do with their ICD-10 transition plans, okay? And while personally, I'm hoping for something aggressive and innovative when they finally do make their statement, I suspect that will confirm October 1st, 2015 as the next version of this implementation date, but possibly not the final. So as such, I recognize that promoting a message of continued progress towards ICD-10 implementation at your respective practices, it's a little bit like asking you to build a bomb shelter because the end of the world is coming. And so it's wrought with conflict, but this is what I would say about ICD-10. ICD-10 is imminent. Whether it's October 1st, 2014, 2015, 2016, or beyond that, it will happen. ICD-9 is no longer an option to advance the value-based purchasing initiatives in evidence-based medicine. ICD-11 is not an option for another 20 years. So as you'll see from my colleague, Dr. Kaplan, in a few moments, ICD-10 really is just the underlying dictionary that defines what is most important to you as practicing physicians. And that's the delivery and the documentation of superior patient care.
Any more questions? Is this going once, going twice? Okay, great, thank you.
Thank you very much, and Jason, for that excellent presentation. Well, we are getting to the end, and I tell you, I was doing my evaluation. This is one of those years that I had to say that all 6 conferences were very good, outstanding, excellent. That we really want to congratulate the speakers. Let me tell you that from my point of view, it's not feasible to do this without Millie. There's no way to do it. There's no way to do it. It may look bad and lazy, but if it's not because she's on top of the time, it doesn't get done. Thank you, Millie. Thank you. Yes. I also want to say thank you to you because, I understand that some of you were dancing until 2 o'clock this morning, and you were here on time. That's very good also. They show you that it's a lot of energy to do merengue and then to come here and to listen to the conferences. I want to thank one of my bosses, Dr. Donald Landry, who is the chairman of the Department of Medicine, because he signed this form, and this year, when he saw the quality of the speakers, and most of them are under him, Dr. Kaplan, Dr. Tenenbaum, Dr. Brown, he said, wow, how did you get these people to come on Sunday? We cannot get them. I say again, oh, that's Millie. That's not me. That's Millie. But on the 9 and on the 10, at Jacob Jevis, the Department of Medicine and Columbia University is holding the first primary care course for clinicians for the 3-state area. This is a conference that we used to do with Harvard. And then Harvard split from us. It was not done last year. We're going to do it Friday the 9 and Saturday the 10. Each of you is a guest of us. And that you can come as a guest and you don't have to pay the fee. It has been established that each of us, as our community physicians, we're inviting you to come to the conference. You will get the credit. You can register through Millie. You will get the credit, and you will go and participate in all the conference free of charge. That be our guest. But, I also want to bring in Dr. Fajardo. Again, thank you to Presbyterian Hospital because they give us this facility for free. To the medical school also because they allow the faculty to be participant with us into this conference. And let me bring in Dr. Fajardo, who he knows because this is an international conference now. We have guests now that come all the way from Los Minas. Who knows where is Los Minas? I say, all the guys from Los Minas. Every year, we get a group of physicians that will come from Hospital Los Minas. Again, like I said earlier today, we're very happy now because they are hosting our medical students over there. And I tell you, the first two groups of medical students that went to Los Minas from Columbia University, these are the senior medical students who are finishing in May, and they were so impressed about the quality of your resident, Dr. Reyes. They were very, very impressed about the quality of your resident, and they were very impressed the way that you practice medicine over there and the delivery of care. I mean, thank you for teaching them. Let me get Dr. Fajardo with you now.
Me toca la parte en español. Todo está dicho. Estamos al final del programa ya. Muchísimas gracias. Este programa no pudo haber sido posible sin Mili Onofreri. Sí. Sin el auspicio, como siempre, de nuestro hospital, New York Presbyterian, Columbia University. Of course, los directores del curso, Doctor La Antigua, el coach Sherman, Miguel Hernández y todo el elenco. Ustedes ven esta gente, nosotros no hicimos nada, ellos lo hicieron todo. No sabemos cómo lo hacen, la fiesta, el doctor Roa, que es el director ejecutivo y presidente de la DMA. Ahí está el incansable Leonardo Paula Cabrera, Cabrerita. Cabrerita le manda a uno 157.3 email al diario con la misma información. Eso quiere decir, para que no se le olvide, o sea, yo creo que tenemos un equipo muy dinámico, el doctor Aponte, el doctor Hernández, la doctora Isabel, la doctora Bello, todos son buenísimos. Y me parece a mí que la Asociación Médica Dominicana necesita personal como este que está aquí parado, porque tarde o temprano todos tenemos que ir evolucionando y dándole el paso a lo nuevo. Señores, yo decía el año pasado que necesitamos nuevos integrantes que comiencen a tener el liderazgo de la Asociación Médica Dominicana. No siempre van a tener a Roberto Morán, no siempre van a tener a La Antigua, no siempre van a tener a Cabrera, a Hernández, a Ponte, a Fajardo, a ninguna de esa gente. Así que si quieren que la Asociación Médica Dominicana continúe 17 años más, tienen que hacerse cargo y parte de esta situación. Gracias y lleguen, va a decir algo. Lo más importante.
Bueno, muy importante. Just remember to fill out the evaluation form, la evaluación del simposio. Muy importante que esa evaluación se llene. Okay, hay una pregunta a las 7 que la pueden obviar, pero después las otras, por favor, llénenla, ¿ok? Esta es la forma como nosotros nos damos cuenta cuáles son los temas del próximo simposio, cómo estuvo y cómo es la forma de reportarlo nosotros a la oficina de CME, por favor, ¿ok? Recuerden aquellas personas que no, que sí van a aplicar para los CME, que pasen por el frente antes de irse a pagar el fee, ¿ok? Pero por favor recuerden, sin esta evaluación no nos podemos mover, ¿ok? Por favor no se vayan sin nada. Please remember, evaluation form, ¿ok? All right? Yeah.
Bueno, sí. Oh, the slide. Oh, yes. I mean, si están interesados en los slides de la presentación, por favor, mándenme un email que le vamos a hacer llegar los slides de todas las presentaciones para que no se lo pierdan. Recuerden entonces que tienen que llenar la hoja de aplicación para los 6 créditos de educación continuada y tienen que ver al doctor Roa porque no es gratis la educación continuada, para que paguen el precio que tiene eso, que es bastante barato. Por otra parte, recordar que la Asociación Hispana de Profesionales de la Salud va a tener su congreso internacional en el Hospital Lincoln, mayo 17 y 18, de 8:30 de la mañana a 5 de la tarde. Tienen muchos temas interesantes, tienen muchos speakers, tanto de aquí como de la República Dominicana. Así que apoyar a la Asociación Hispana de Profesionales de la Salud para mayo. Y también recordar nuestro simposio de la obesidad para mayo 22 de 6 a 8 en la Isabela. Todo el público está invitado, profesionales de la salud, padres, madres, hijos, para discutir esta gran problemática que incluso afecta grandemente al Alto Manhattan, la obesidad en los niños. Así que buenas tardes y muchas gracias.
Muy bien, damas y caballeros, estamos aquí al final de esta gran jornada de la Asociación Médica Dominicana, celebrando su 17º aniversario. Ayer estuvimos en una fiesta abarrotada, a casa llena, donde reconocimos personalidades importantes en el ámbito de la política, el arte y también de la medicina. Luego hoy aprendimos muchísimo en este simposio, unos expositores excelentes, temas importantes para nuestra comunidad de Inwood, Washington Heights y de toda el área de Nueva York. Y tenemos aquí a los doctores Valderrama y el doctor Howard y queremos preguntarles sobre su impresión acerca de este magno evento que culmina en esta tarde ya como alrededor de las 4 de la tarde. ¿Cómo se sienten y qué opinan de este evento?
Gracias, doctor Hernández. Este evento ha sido un éxito para los médicos de la comunidad y un éxito para la comunidad. Nos ha podido dar información que nosotros podemos utilizar en el tratamiento de nuestros pacientes, información de los más altos niveles del New York Presbyterian, y aquí es donde la mejor medicina de Estados Unidos se practica. Y estamos muy agradecidos al hospital y los participantes de esta conferencia en la información que nos pasó.
Muchas gracias, doctor. El doctor Howard es un amigo podiatra conocido de la comunidad. Doctor Howard, ¿qué le pareció la fiesta y el evento de hoy?
I would like to thank Dr. Hernandez and all the members of the board for putting in much time and effort on a spectacular day, as well as New York Presbyterian. I learned a lot, we all learned a lot, all relevant topics. Thank you again.
Bien, señoras y señores, seguimos aquí entrevistando en este simposio que fue todo un éxito. Queremos saber del público que participó, qué le parece el evento, la fiesta de anoche y este simposio de hoy.
Para mí maravilloso, soy la doctora Sandra Matos Adame y soy directiva de Medicó, una de las cooperativas que ha ayudado en este evento. El evento de anoche fue maravilloso, la fiesta, todo muy interesante, las premiaciones a la doctora Bello y a los demás doctores. Y hoy este simposio es maravilloso, se ha aprendido mucho, hemos aprendido cosas nuevas ya del 2014 y esperamos que continúe cada año llevando la educación a los profesionales y a la comunidad, como siempre lo ha hecho la DMA. Gracias.
La doctora Elba Rosario, ¿qué usted opina de estos eventos?
Sí, yo soy la doctora Elba Rosario, presidenta de Medicó y por ende también miembro de la DMA. Estoy más que maravillada de este evento, igual que el de la noche pasada. Esa fue un rotundo triunfo, esa fiesta donde tuvo la intervención de tantas personalidades diferentes, tantos médicos como de la área política. También el simposio de hoy, muy interesante porque veo que esto nos lleva a compenetrarnos con lo que es la comunidad, porque por ejemplo el tema referente al tratamiento con los pacientes de la hipertensión, de la obesidad, que no tienen un follow-up. Entonces sería muy interesante que nosotros nos integremos más para trabajar con el paciente en lo que es el assessment del paciente, la continuación de ese paciente y así tener también una cosa que sería muy importante, que el médico dedique más tiempo, tanto como los profesionales que trabajan con los médicos, como los consejeros, las enfermeras, a tener un tiempo más con el paciente de interacción, para de esa forma uno poder entonces llegar a lo que es la finalidad del problema del paciente.
Gracias Sandra Matos, gracias Elba Rosario por esta intervención y esta es la idea, que estemos unidos, Medicop, todos los sectores, no solamente del área de la salud, pero todas las organizaciones en pro de la comunidad, porque tenemos que hacer un cambio, debemos de tratar de llevarle ese mensaje a la juventud, a la nueva generación, de que se puede triunfar aquí, y de que es posible llegar a ser profesional y ejercer en Estados Unidos. Ha sido un éxito esta entrevista, así como la fiesta y el simposio que realizamos el día de hoy. Muchas gracias.
La fiesta fue magnífica, el sitio elegantísimo y estuvo muy bien atendida. Yo me sentí muy contento de haber asistido a la fiesta anoche y al simposio hoy. Este tipo de actividad pone en alto la Asociación Médica Dominicana y dejar ver qué papel juega en la comunidad dominicana.
Muy orgulloso, porque yo digo que hoy quizás, y parece un cliché, tuvimos el mejor simposio de los 12 años en que se ha celebrado este evento. O sea, las 6 conferencias fueron magníficas, pero también conferencias que nos hablan a nosotros de qué está pasando en el mundo de la medicina, ¿no? Oír hablar de hipertensión y lo que es el programa de hipertensión en el 2014, oír hablar de los nuevos tratamientos de la hepatitis, oír hablar de la nueva codificación que viene para hacer el diagnóstico a los pacientes, oír hablar, como nosotros oímos hoy, de prácticamente, o sea, lo que es un medical home, o sea, 6 conferencias magníficas dadas por excelentes profesores de la Universidad de Colombia y otras instituciones. Yo creo que ustedes, o sea, todos los que participan en la organización de este simposio deben sentirse orgullosos con la asistencia excelente, o sea, ver 3 generaciones aquí de profesionales de la salud en el campo de la medicina, ¿no? O sea, estudiantes de medicinas, residentes y médicos en la práctica, no debe sentir el orgullo que se junten todos, pero también ver otras profesiones junto con nosotros, enfermeras, asistentes médicos, PA, nurse practitioners, también indica cómo nos vamos expandiendo y entendemos que la medicina debe ser practicada realmente en grupo. Obviamente un éxito desde el punto de vista científico, un éxito desde el punto de vista de la asistencia y un éxito desde el punto de vista de colaboración del Hospital Presbiteriano y la Universidad de Colombia. Y como te decía, estoy seguro que al final del evento todos nos sentimos orgullosos de ser partícipe de su organización.
De hoy todo un éxito, nos da un tremendo, un profundo orgullo de poder haber logrado. Uno siente la satisfacción de haber cumplido. Así que estamos muy contentos y seguimos adelante con estas entrevistas.
Estoy contenta, estoy satisfecha. Creo que ver el crecimiento y el desarrollo de la sociedad médica dominicana es muy satisfactorio. La calidad de los presentadores. Cada año nosotros tenemos un evento que es más exitoso y con mucho mejor calidad. La fiesta lamentablemente no pude participar, pero sí oí decir que es excelente como todo lo que ustedes organizan. Y el simposio de hoy, la conferencia médica acerca de los temas realmente que impactan nuestra comunidad en cuanto a los problemas no solamente de salud, sino también a cómo los cambios que vienen en el nuevo sistema de salud van a impactar a la comunidad médica y también a nuestra comunidad en sentido general. Creo que hemos tenido un día excelente hoy. Muchas gracias.
Sí, qué pena que se perdió la fiesta, pero la asociación sigue tratando de hacerlo mejor. Y hoy se demuestra una vez más que estamos siempre progresando y este simposio fue todo un éxito, pero este simposio no pudo haber sido exitoso si no contamos con la presencia de personas como tú, de doctoras como la doctora Olivero y otros doctores que estuvieron aquí y dijeron presente. Muchas gracias, seguimos con las entrevistas más adelante.
En primer lugar, quiero darle las gracias a la Asociación Médica Dominicana por el gesto de reconocer el trabajo que durante 40 años hemos venido realizando aquí en la comunicación en Nueva York. Los felicito, fue un éxito rotundo la actividad de la fiesta, la gala anual y el simposio del día de hoy definitivamente marca una nueva etapa dentro del trabajo que vienen realizando ustedes como asociación para beneficio de los miembros, la clase médica dominicana radicada aquí en la ciudad de Nueva York.
Muchas gracias. Y a él no se le puede discutir, él dice que fue todo un éxito y estamos convencidos de que así fue. La fiesta y el simposio fue todo un éxito y nos sentimos bien satisfechos por lo que hemos logrado. Así que sigan en sintonía con estas entrevistas de lo que pasó en el simposio médico de la Asociación Médica Dominicana, esta vez el 12º. Muchas gracias.